is selective laser trabeculoplasty. Is it the first choice? Dr. Bhaswati Sahoo, right? Sir, ma'am, thank you. Please, over to you.
Thank you very much. First of all, I'd like to thank the organizers of AIOC for giving me an opportunity to share glaucoma in this forum of around the world. So the topic for today, which I'll be covering, is selective laser trabeculoplasty, and this has definitely caused a paradigm shift in my clinical practice. So selective laser trabeculoplasty, is it your first choice? I have nil financials to disclose. When we talk of glaucoma, the aim of treatment is to preserve the residual vision while achieving the best quality of life. And quality of life today plays a very important role in glaucoma management. The only modifiable risk factor in glaucoma is intraocular pressure. So our main target is to reduce the intraocular pressure. And currently, how do we do it? If we see the current modality of treatment in most of the clinical practice is medical management. So we start with the one drug, which is the prostaglandin analog. If we have failed to achieve the target intraocular pressure, we go on to either add or switch to another treatment, then add in a third line of drug, and trabeculoplasty forms usually the fourth line of treatment. Now, we have to consider certain factors in any kind of treatment. So is the therapy sufficient? Is it sustainable? Is it tolerable? And is it affordable? So when we think of medical management, the most important barrier to therapy is adherence. And the factors may be multifactorial. We have old patients who often have cognitive and impairment, so they are unable to put in the drops. We have the socioeconomic factors in developing country where the glaucoma drops are usually very costly. In developed country, because of the long wait period, continuity in care is a big problem. And then we should not forget the side effects of the glaucoma drop. Now, if we see this patient is a patient who has been using prostaglandin analogs in one eye. So would you be happy with this look if you had glaucoma and was prescribed some drops? Well, I would not. So that's the reason we have to think of other options when we are managing glaucoma today. So while moving to laser, just let's take a peek look at the past of laser. So the initial trial with laser was using goniopuncture with a ruby laser, which produced a temporary lowering of intraocular pressure. In the 90s, Weiss and Witter in 79 were the first one to introduce argon laser. And they were able to achieve a lower intraocular pressure, but the effect was short-term. So what Anderson and Paris came up with is the concept of selective photothermalysis, and this has since then changed the entire thinking or thought process about laser. Now, what is selective photothermalysis? It states that it is a phenomenon which needs two important things. One, there has to be an intracellular chromophore in the target tissue, which is the trabecular meshwork here. That target tissue should have a greater optic absorption at the laser wavelength as compared to the surrounding tissue. Secondly, the duration of laser should be less than the thermal relaxation time of the tissue. So now with argon, the first point was achieved, which means the melanin pigment in the trabecular meshwork causes a selective absorption of this laser. However, the laser time of the argon laser was 0.1 second, which was much longer than the thermal relaxation time of the melanin pigment, which is 1 microsecond. And this was the problem which led to laser-induced burns, the formation of peripheral anterior synechia, and it did not show a success in ALT when the procedure was repeated. So the adverse effects of ALT or argon laser was related to this thermal effect. So there were very high acute IOP spikes following the procedures. There were formation peripheral anterior synechia, which causes the effect of laser to wear off. There were damage to the corneal endothelium. there was severe inflammation, and the glaucoma surgeons found that the chances of encapsulation of bleb following trabeculectomy in these patients was almost threefold higher. So that shifted the main idea of laser into another laser, which was selective laser trabeculoplasty, and this was invented by Latina and Park in 1995. Now with SLT, the 2 points of the selective photothermalysis was taken care, and that is why the side effects of the laser or the collateral damage was minimum, and it got the FDA approval in 2001. So when the histopathological studies were done in patients using argon and the selective laser trabeculoplasty, it was seen the selective laser trabeculoplasty mostly acts by inducing biological changes by increasing the gene expression and cytokine production, and did not cause much of structural damage as compared to the argon laser. Hence, it was a repeatable procedure. So there are certain predictors of success in SLT. The higher the baseline intraocular pressure, the better is the response, which means if a patient comes to us with a very high pressure, we expect a more or a better result in that patient following a selective laser trabeculoplasty. Secondary, higher the trabecular pigmentation, better is the response. And that's why selective laser trabeculoplasty works very good in pigmentary glaucoma. Also, there were studies which showed that if the patient has had a positive response in one eye, the chances of the other eye getting a positive response was much higher. So the conventional SLT is done by using, all you need is the SLT machine. These days we have the Duo machine with the YAG laser. So all you need is a separate lens. So we can proceed either 180 or 360 degree with a power of 0.8 millijoules, and we look at the champagne bubbles and expecting it to be present 50% of the time. The adverse effects are very minimal, except for some elevated IOP or minimal inflammation. Usually, I have not come across any of the other things. Now, we did a clinical audit at our place over 1 year. We have enrolled different types of glaucoma, and the intraocular pressure was seen a reduction of 72.95%. Also, there was a reduction in the number of drops. Almost 56.9% of patients showed a reduction of 1 drop, and 37.39% showed a reduction of 2 drops. Now, what has changed the entire or provided a leading edge to selective laser trabeculoplasty is the LIGHT trial. LIGHT stands for Laser in Glaucoma and Ocular Hypertension. This is a randomized controlled trial which compared medical management versus SLT, keeping into consideration the quality of life questionnaire. Although there was not much difference in the primary outcome based on the questionnaire, what this trial showed us that 74.2% of the patients who underwent SLT reached the target intraocular pressure and were drop-free at 36 months, which I feel is very encouraging. Also, this means there were 5 times less medication drop-related adverse effects. The COAST trial, or the Clarifying the Optimal Application of SLT Therapy, is the new ongoing trial which is trying to further reduce the power of the SLT. So it is a study which is comparing the conventional SLT with COAST SLT, wherein you repeat the patients every year with a very minimal dose of 0.3 millijoules, whereas in the conventional you start with 0.8 millijoules. So this concept is devised from our retina colleagues who undergo the Avastin like PRN and treatment and extend principle. So this is basically based on that. It's still ongoing, but the initial results have been very encouraging. So to conclude, SLT is an effective option to reduce intraocular pressure with minimal adverse effects. It preserves visual fields with a good quality of life. It's cost-effective, more tolerant with no ocular surface problems, and it is a repeatable procedure. So if today, if anybody asks me, is it your first choice, rather than asking why, my question would be why not? Thank you all for your kind attention.
Thank you, Dr. Sahoo. That's a wonderful presentation. And thank you for flying over all the way from New Zealand.
Thank
It's
you.
great to have you here. Any question, delegates from Johan? Yes, please go ahead.
So with the permission of Chair, and Dr. Shah, thank you very much for the SLT presentation. Actually, I agree also that SLT is the first choice for the primary open angle glaucoma, even in the secondary pseudophakic glaucoma, if it is open angle. As you are working in New Zealand, right?
Yes.
So I think it will be different than Bangladesh, India, the power energy. Because in my country, we use 0.9, sometimes 1.0. But maybe the white people, they need a less. Another question to you that you have shown 180 to 360 degree. Actually, what is the routine procedure? You do 180 degree or 360 degree in all your cases?
Thank you for your question. Now, there are two parts of the question. Let's move on to the first. In fact, the white people, they need more energy because the trabecular pigmentation is fainter in there. So if you see, if the trabecular pigment is more, the power needed is less. And that is what, in pigmentary glaucoma, we might be able to achieve a champagne bubble at 0.3, 0.4, whereas in a normal glaucoma in white patients, so we need a lesser power, a higher power. So in Indian eyes, in fact, when the trabecular meshwork is very pigmented, we should be able to get away with a lower power. Now the second thing is, mostly because for us, there is a long wait period. So I go for bilateral 360-degree treatment in the same sitting.
Okay.
And that has not shown any kind of adverse effect as of now. The only thing which we get is the IOP spikes.
Yeah.
But if it is a pigmentary glaucoma patient, there I need to be careful because I know these are the patients who present with a very high IOP spikes or the inflammation is high. So there I would want to do 180 degree in one sittings and then go for, in the next sitting, do the next 180 degree. But studies have shown there is no difference between the two. So it's basically an individual choice and depends on what setting you're working at.
Thank you. I have another quick question. What is the post-operative follow-up about the treatment? What do you give?
So initially, after doing the laser, we make the patient sit for an hour to record any kind of IOP spikes. If there is no IOP spikes, I just give NSAIDs for 10 days, and that's about it.
NSAID, not a steroid?
No.
Yeah.
Look, the studies have shown that either steroids or NSAIDs can be given. They have equal results. But with steroids, there is always a chance of we don't know which patient is a steroid responder. So
Yeah.
I usually avoid the steroid. We give NSAIDs for all patients. And if the pressure, because these days I just don't do SLT only in mild glaucoma, I do SLT in all patients as the first choice. So my intraocular pressure depends on the target pressure of that patient. Let's say the patient is already on 4 drugs and I have done an SLT. So I will do NSAIDs for 10 days. I will reduce the patient drops by 2 drops, not all the 4, 2 drops, and usually see after 4 to 6 weeks. 4 to 6 weeks is the usual response of the SLT to be seen. There are few of the patients who are late responders who can respond up to 8 weeks as well.
Thank you.
So
thank
6 to 8 weeks is the time.
Dr. Sahoo, thank you very much, and safe journey back home.
Thank you.
Okay.